So, hello, my dear friends. This is Professor Pradeep Kumar Dabla, um, a professor of the Department of Biochemistry, JB Pant Institute of Postgraduate Medical Institute in Research in Delhi, heart of India, the capital. And I'm also attached with the IFCC as a consultant, as a task force consultant for the Task Force Young Scientists, and also with the IFCC Emerging Technologies Division as a member of MHPLM committee, and also a member of the APFCB Communication and Publication Committee, and also participating as an NABL Assessor for Medical Laboratories as per ISO 15189. So here, this is my slides about my institute, that is the JIPMA, which is a super specialty institute of the capital of India, that is Delhi, under the government of Delhi, and is working for super specialties like the neurology, cardiac sciences, the psychiatry, and the gastric sciences. Today I'm going to discuss my slides into the different heads like the clinical test, where the lab stands, the evolving cardiac biomarkers, the opportunities for improvement, and the different AI challenges that we are facing in the current state. So, when we are talking about the clinical test as a part of laboratory, so of course the patient is very important in today's era, because the patient is playing a much larger role into the decision making, and it is always into the great demands towards the health services, of course, because the information is widely available onto the internet. And for that reason, as you can see, because of going for more complexity of the clinical testing, where we are trying to shift our strategies from the one medicine which fits all and every people to the precision medicine, which is a personalized medicine. So today's clinical lab is becoming one of the hospital's largest departments, and thus providing the vital information for the effective healthcare delivery. Thus, the laboratory is becoming the important source of the diagnostic information. Now, when we are talking about the cardiology, so as a part of laboratory, I see the cardiac biomarkers refer to the substances which are released into the bloodstream due to the heart-related damages or the stress. And the global cardiac biomarket size is expected to reach about the US dollar 26.33 billion by 2027, and it's exhibiting a compound annual growth rate of 11.2% during that forecast period. It is being provided by the news report by the businesswire.com London. And because of the reasons, the cardiac biomarkers, the market is expected to witness a significant growth in the near future. And if you see, uh, in addition to the technological innovations, and because of this increasing the older population and rise into the cardiac diseases, and there's also we are needing more of improvement into the healthcare infrastructure, and it also these are the combined significant growth drivers for this high rising market of the cardiac biomarkers. Well, when we are talking about the emergency services, because our talk is going to more concentrating toward the emergency services of cardiovascular diseases. So we have the two cardinal biomarkers, which are the evidence-based, guideline endorsed, and also the widely the clinically applied markers. The first is the cardiac troponins, which are now the essential requirement for the diagnosis of the myocardial infarction, and they also they govern the immediate management studies with respect to the need for the early invasive intervention. Whereas when we are talking about the natriuretic peptides, they have partially filled the formerly unmet needs to improve the diagnostic certainly, and to provide the early risk stratification in case of the acute heart failure. Thus, questions are, what remains to be done and what is the present and the future needs. So here we see the importantly that we need to know that when we are talking about the cardiac biomarkers and laboratory as a stakeholders, so where the lab stands. So you see approximately the 2% of the patients with the acute MI have the diagnosis missed into the emergency department, and more and large there are the few very specific reasons has been identified for the same. Firstly, the inappropriate discharge of the acute MI patients, which has been found, the core problem in is admission of patients with a low probability of the acute coronary syndrome, where we may miss cases requiring the urgent help, and the patients, those who have some atypical symptoms, like in case of the coronary, the artery plaque rupture, or we call as the acute coronary syndrome. The next is the decisions onto the testing protocols, which are often made without the input from the laboratory people or without the input from the laboratory medicine. It means that the laboratories should work with the emergency physicians and with the primary care physicians, with the cardiologist, and the hospital administration. And at a chest pain centers, the rapid AMI rule-out protocol are very essential for the early MI cases, which are powered by the ECG testing, the timely blood collection for the measurement of the cardiac biomarkers, and respectively the more measures. The lastly, the important, the significant, the factor is the quality assurance, where the role of the regulatory compliances comes, and it is the important aspect of the regulatory compliance as well. For example, is the registry data. Going to the next. So when we're talking about the cardiac biomarker, so what is the new into this system right now? So in the rule out acute myocardial infarction process, the cardiac troponins is the sole recommended biomarker, and using the 99th percentile cut point, and with the two lab results drawn at the time between the 0 to 3 hours, and 0 and 3 to 6 hours specifically. And when comparing the US hospitals to the guidelines, only it is surprising to know, but only the 24% use the cardiac troponin only strategy, whereas the 49% use the 99th percentile cut point, means the two lab results at the 2 points at the two different time zones, and the 35% rule out the myocardial infarction within 6 hours. So you can understand these strategies are also being differently drawn at the different places. So it is not consistent with the recommended guidelines, which are leading to an increased cost in the longer acute MI rule out times without the clinical benefit to the patient. So when we are talking about the monitoring and the measurement of of these units, or the role of the lab personnel, so it is very important, because the selection of devices, whether the education and training being required to how to use these biomarkers, their timeline, their turnaround time, etc., whether it is verification, whether it is compliance. So everything is very much related to the expertise of the lab personnel only. One of the important point is also being discussed is the reimbursement for the testing protocol. For example, if you see the Center for the Medicare and the Medicaid Services has announced that it is not necessary to use the troponin in addition to the creatine kinase, which includes the MB ISO enzyme, that is the CKMB, while in the management of patients with the MI, that is myocardial suggesting that the reimbursement will not be allowed to from the companies when both tests are being ordered. It means that the private insurance companies may also limit the reimbursements for the correct biomarkers. So it means that the guidelines should be very specific and should be drawn by everybody for the benefit of the healthcare and for the benefit of patients. So going to the next, before we go ahead, going into the AI, that is the artificial intelligence of the cardiac biomarkers, let's have a look more into the laboratory, precisely into the laboratory setup of the cardiac biomarkers, precisely again into the emergency settings. Uh, although the time of chest pain onset for the AMI patients sometimes is known. This information is less available, or you can say it is less reliable for those who are coming with unstable angina. Indeed, there are many patients with the acute coronary syndromes who experience silent ischemia and infarction. That means there's no pain during the occlusive episode. So that's is it really that repeat cardiac biomarker testing is leading to the earlier detection and use of the appropriate therapies? Is it really true? Let's have a look at it. So when we are talking time, that means we are focusing towards the utilization and the ordering. It is a complicated phenomena because laboratories need to consistently delivering the 90% of the cardiac biomarkers that results should reach to the patient area within 30 minutes. That means it is a very high amount of expectations while maintaining the turnaround time. Whereas the results of cardiac marker testing are not used to guide the thrombolytic therapy in practical means. And as stated earlier, there is no clear evidence that the availability of rapid biomarker thus leads to the better patient outcomes. So yes, which this concept does not support the need of a very rapid turnaround time or any single sample. So it means that we are going towards the 99th percentile theory. That means we have to take the samples at the two time zones, one at the 0 to 3 hours and then at the 6 hours. Now the next important point to consider in case of pre-analytical aspect is the sample type. So of course, when we are talking of plasma for the measurement of cardiac biomarkers, that really eliminates the extra time which is necessary for the clotting process when we are requiring the serum. Therefore, it also reduces the overall turnaround time for the cardiac biomarker testing. So it is very important that which type of sample we are using and which type of testing we want in that sample type. The next is uh, the 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 interference by the lipemia, the icterus, or the hemolysis. So, however, the several cardiac troponin assays are influenced by the hemolysis, and the magnitude of interference is related to the cardiac troponin and the free hemoglobin concentrations. Excess of lipids or proteins can also prevent the proper aspiration, thus leading to the inadequate sample volume. The next is the sample stability. However, the several studies have been documented that the cardiac troponin concentrations are relatively unaffected during the short-term span of storage, that means at a 4 degrees Celsius or -20 or -70, when being properly separated from blood cells and stored properly. However, the long-term stability is less understood and being less studied, and where the more planning may be required in that case. Lastly, the important is the delta check. The diagnosis of AMI necessitates observing a rise and or fall into the cardiac troponin concentrations. That means that we want to mark a change, whether the disease is progressing towards the worsening or it's getting better with the treatment, which requires at least the two cardiac troponin measurements in most clinical scenarios. And for the contemporary assays, the testing intervals of at least the 3 to 6 hours have been shown effective at increasing diagnostic accuracy. Um, um, uh, then the third point important is defining the clinically relevant threshold values is again complicated, and the international guidelines for the diagnostic acute microinfarction endorse the implementing of the 99th percentile of the healthy population as a upper reference limit, but it do not define the specific strategies, or it does not specifically define that how to rules. It does not specifically define the rules which can be used for detecting that significant delta. The fourth important point, while we are checking delta, that means the difference of the two values, is that the studies of both the cardiac troponin and the cardiac troponin I assays being poorly harmonized, and as such, it is complex to translate the clinical or analytical data between the assays. Now going to next, the analytical part. Again, rapid turnaround time, which remains in the four most important area of to have the lab results that will lead to the expedite uh, patient discharge and also reduction into the complications. So again, when we are talking about the cardiac emergency, we need to define as the ST segment elevation MI or as non-ST segment elevation MI. However, the results from the serum cardiac biomarkers are not needed in making the acute treatment decisions into the STEMI patients. And when we are talking about the point of care testing, of course, now the various instruments are being available, which are doing a wide level and wide range of the test menu, and also can do the myoglobin, the CKMB, the cardiac troponin T, cardiac troponin I, and many are available into the multi-marker formats as well. These assays make the use of the anticoagulant whole blood, and can have the analyzer times of about the 20 minutes. Thus, it is having a long impact into the length of stay of patient. Thus, it can reduce the length of stay. It can also reduce the lab cost because of the rapid availability of the testing results and reporting of the cardiac biomarkers, as well as important ones, the important markers, the natriuretic peptides. Going to next. When we are talking about the analytical variability, so it means that the what are the interferences which can interfere with the testing of that particular cardiac biomarker. As far as concern of the cardiac troponin immunoassays, there are the anti-cardiac troponin antibodies has been identified, which are known as the heterophile antibodies, that can lead to both the false positive and the false negative results. But in practice, false positive results are more frequently reported. Overall, the prevalence has to be estimated to be 0.1 to 3%. Uh, um, the while the exact mechanism of that remains elusive of these heterophile antibodies, but they bind to the reagent antibodies in a manner that links the solid phase and the detection antibodies, thus enabling them to form a sandwich, a kind of complex together, and gives the appearance of the quantifiable analyte. Thus, it is interfering with the results, and overall the prevalence has been estimated to be 0.1 to the 3% into the cardiac troponin assays. Now, the next is the instrument malfunction, where we can say the flyers or the cardiac troponin results that are initially significant significantly decreased cardiac troponin concentration, which again with the clogging the equipments as having a the artificial component as well. The cardiac troponin harmonization, which has been poorly harmonized between the cardiac troponin, which has been coming to the next, that is the post analytical we need uh, the image of the cardiovascular diseases or the uh, uh, we need the quantitative interpretation for sure. We need to identify the optical medical point, positive or negative values. It can also help in strengthening the risk stratification. For the diagnostic threshold, it is defined as the 99th percentile of a healthy reference population as the diagnostic threshold to identify the myocardial injury and to aid into diagnosis of MI. In 2018, expert opinion from the Association of Clinical History and the I diabetes troponin I2 criteria. First, the high sensitivity percentile is less than 10%. Sensitivity methods should measure the cardiac troponin concentration above, and the method that it should be available into at least 50% of the healthy subjects that are enrolled into the large populations. Thus, detecting that the delta change is very important, where we are trying to find out the change into the values of the cardiac troponins over the time, in spite of a single absolute concentration. One more important is also I want to share. Yes, it is the result reporting. What we perceive, what our eyes see to it. So, for instance, the 200 nanogram and 0.2 nanogram per ml are identical. The first unit choice makes the results seem high, whereas the second makes the results seem low. So it also very important that what is the unit we are receiving, to report the correct biomarkers. Next is important is how the evolving cardiac biomarkers are with the technology. So the source of new biomarkers has been, identified as six major axes, like in case of inflammation, in case of oxidative stress, in case of neurohormone activation, renal dysfunction, and the cardiomyocyte injury, and the matrix remodeling, as you can see into the picture. Important to improve the risk stratification and guide uh, for management of the patients and the settings, and is helping into the early diagnosis and to rule out and the triaging of patients from inside. Uh, Also important is, the risk monitoring settings. As for example, the type cardiac nucleotide peptides and the cardiac troponin of function in changes. Uh, Also, as per the technological advancement, it also enables the extensive screening of markers in any given cardiovascular disease patients. Thus, that system biology approaches towards the omics is becoming more and more widely acceptable for the research area. That includes the proteomics, metabolomics, and exploration of circulating nucleic acids, including the microRNA. And it also includes the non-coding RNAs that are screened on extensive nucleic acid chip arrays. Now, coming to the important area, that is the artificial intelligence, or we call as neural network. So artificial intelligence, by and large, describes a range of techniques that allows the computers to perform tasks that require the human reasoning and problem-solving skills, using either the predetermined rules and search algorithms or patterns which are, recognizing the machine learning models. Thus, it processes a large amount of data and recognizing patterns into the data. Thus, it is also called as the Internet of Things. Again, neural network is a common type of machine learning which is inspired by the way as the animal brain works. As you can see into the picture, the several dots which are interconnected with each other into the multi-layer network. So it is a multi-layer network of interconnected units like the neurons that process the information by responding to the external inputs, thus relying to the information which is flowing between the different neurons from one to another. And as you can see into this model, for example, example of one cancer cell has been taken, that how it being differentiated between the healthy or the cancer cells, including the input of the different factors like the morphology, the height of cell, the stiffness, the thickness, and these information correlating each other as a blue dots with the inter deep layers and giving the output as a yellow dot or the cancer cells. Now the evolving biomarkers are also happening with the advancement of the technology, and the AI has led to the significant paradigm shift into medical knowledge. And the omic data, of course, in case the input data is quite varied, which is ranging from the socio-environmental to the clinical laboratory or to the omic data. And AI is having a positive impact, including the radiology, pathology, whether the ophtha or importantly the cardiology as well. For example, if you see, the congestive heart failure, an illness that was afflicting about the 10% of the senior citizens, and the estimated cost was about the 35 billion each year, 35 billion $, each year into the United States. AI tools are helpful because they have helpful in predicting the advanced potential challenges ahead and allocate the resources to the patient education and also to the sensing and to the proactive interventions. And machine learning is also a part of the AI being used uh, as a terminology against the AI only. Now here are the few papers, as you can see. Okay, so here are the few papers, as you can see in my screen, that in patients those are presenting to the emergency department, the machine learning techniques using the patient data, whether including the age, sex, or risk factors, the chemical markers, the genetic markers, could improve the diagnosis and then also the triage. Uh, as you can see in a paper by, okay, right. So as you can see into the paper by Shea et al., they have evaluated the data science and approaches to reduce the misdiagnosis and enhancing the triage procedures of the non-STEMI for the non-cardiogenic chest pain. And they have built the artificial neural network. They showed an area under the receiver operating characteristics with the accuracy of about the 98.4 to the 98.6% respectively, which is quite a huge success, I must say. And in another paper by the Martin et al., the machine e-learning algorithm incorporating the and time collection with paired sensitivity cardiac troponin I concentrations was trained onto the about uh, three 3,000 patients and tested onto the about 8,000 patients with suspected myocardial infarctions. And in another study by the Wang et al., as you can see, it showed that the AI, that is the machine learning, can improve the cardiovascular risk prediction by correlating the complex interactions between the risk factors. And researchers by this study have provided data on to the about 295 about the 100,000 patients to four medical learning algorithms for the training purposes, and they have tried correlating the medical history with the heart attack rates, and they have found these algorithms performing very well and been correlated even better for their diagnosis with the when they have compared with the American College of the Cardiology. And they have showed the one about the 2% fewer alarms into these studies. So it means that by all means that laboratory is quite important in case of a patient care. Thus, um, the fundamental importance is to ensure that the patient is given the high quality care by adding the value to the lab test. Thus, the test should be clinically valid, which can provide the highly accurate diagnostic information. It should be clinically effective. That means it contribute to improve the patient care and the patient outcome. Test results should be cost effective, so they can provide to the reduced healthcare cost. And in all that, if you see the interprofessional collaboration is very much needed, where the clinical decision making should also take the help of the laboratory services. Thus, the contribution of laboratory services to the clinical decision making uh, not only depends onto the performance of laboratory itself, but also onto the behavior of the clinicians with regard to requesting the test and and seeing the trends and using the results. And these interprofessional collaboration highlighted the factors that shape, the interface, including the responsibility, accountability, coordination, whether it is communication, and many more the factors which are important, uh, to develop the mutual trust and respect between the clinicians and the laboratory of the hospital services. So, in today's era, the needs of clinician, if you see, as per the studies, it has been identified that now the needs of the clinician from the clinical laboratory is more toward the diagnosis, so that they can help into the treatment selection as compared to the monitoring or as compared to the screening. But it should not be like, giving a test menu to the patient and asking him what you want to do. So that means we need more of robust mechanism for diagnosis of the patient patient disease, so we can help into the better outcome. So there are the few opportunities for the improvement has also been seen. For example, improving the adoption and adherence to the evidence-based laboratory medicine. The much of the work has been started into the various countries like the UK NICE, the National Institute for the Health and Care Excellence Pathways, that offer the interactive online clinical algorithms that is linked to the detailed evidence-based information from diagnosis to the treatment options. Similarly, the computerized physician order entry, that is CPOE, and also the NOCLUS, the Norwegian Quality Improvement for the Laboratory Services in Primary Care. That means the clinical audit are also very important part of the current testing system, in fact. So that we can, have a more evaluation of the requesting patterns and the test related outcomes. We can also, couple with the individually tailored presentation of findings uh, to reduce the inappropriate requesting patterns. Now, as a part of the medical college and as a part of of the healthcare system. So I'm trying to, concentrate that what is being taught to our medical students into about the laboratory medicine into the current situation. What are the future doctors learning today about the laboratory testing? Are they really going well about the laboratory testing? Are they really know that the laboratories is such an important part of healthcare system? Uh, so you see, in that case, as per my experience, the limited knowledge of clinicians about how the laboratory functions and how to interpret test results may have arisen, because the pathology being taught into the medical schools is predominantly is the anatomic pathology, more less of a chemical pathology, and so because we have limited teaching of laboratory medicine into the medical schools. We rarely talk about the test selections. We rarely talk about the result interpretation. We have a limited instruction and the training courses on test selection and the laboratory setup. So to pass, if you say, the most medical students must know what a heart looks like under the microscope after heart attack, that they should be identified, but not what the blood tests are needed to diagnose a heart attack. But I'm sure that we all know that um, uh, no one does a heart biopsy to diagnose a heart attack. So that means the integration of the pre, para, and the clinical subjects is an important area that we cannot be forgotten. So to have the to to conclude this particular important lack of medical education, the Medical Council of India have emphasized from 2019 to the new curriculum for the undergraduate medical teaching, and they have introduced the early clinical exposure. And what is this ECE? That is the teaching of the learning methodology, which fosters the exposure of the medical students to the patients as early as the first year of the medical college. That means you you may bring your students to the real health settings, real clinics, where you can they may be uh, helping as an observer, um, from the classroom setting to the hospital setting, or may also to the community setting. And one can also use the cases to teach in the class with the help of the paper case, or maybe the photographs, the x-rays, laboratory tests, ECG, and so on. Yes, of course, not only the doctors, but the training of our paraclinical staff, education, and the continuous training is also very important. So I have shown the slides in one of the picture from the latest and the recent the CME that we have conducted into our department in 2019, though everything has been stopped after the COVID pandemic in 2020. Yes, AI is beautiful, but it also has some challenges to address. Importantly, the reliability of making clinical decisions, protection of patient data with respect to privacy, whether having an impact onto the doctor-patient relationship, the accuracy, the medical, legal, ethical implications for the practitioners, its utility to the clinical practice, and its utility in respect of the the claimed outcome, the lack of data, because yes, the AI has done a lot into the many places, like into our grocery settings, into the many more areas, but yes, into the healthcare settings, it is still having the limited span. So there are a few guidelines have been given, like for example, by the FDA US, where the policy for the device software function and mobile medical application guidance was first issued in 2013 and further updated in 15 and 2019 as well. So to conclude, in addition to redefining the building upon studies to enhance diagnosis and prognosis of upcoming AI focus into the cardiology, that should include the development of AI-driven algorithms to aid the clinical decision making in test appropriateness, test selection, scheduling, workflow prioritization, protocol, patient management. These developments will not replace the role of physicians and other healthcare professionals, but it will definitely going to improve them with the highly accurate tools to detect the disease, stratify risk in more consistent manner, and optimizing the patient-specific management. So there's a need for the growing cooperation and to provide the guidance on the test selections and for the interpretation of the analytical results.